I mean, addressing health inequalities is essential, and I think what we know is that people's health needs are impacted by wider determinants of health.
It's really a long-standing injustice that some groups and populations and communities experience significantly poorer health, and it's those people who tend to need health and support more who tend to experience the biggest health inequalities and barriers to accessing our services.
People with a learning disability still die on average 20 years younger than non-disabled people, and many of those reasons are completely avoidable. They're due to health inequalities.
In our county, we know there are people living in certain parts of the county who are going to live less years than other people, and that's not to do with anything other than their circumstances in which they live, their life experiences, their opportunities, etc. We can do something about that to reduce that gap.
Building awareness around not only what health inequalities are, but the ways that we can work to decrease them, especially through engagement, through listening to people when they might not necessarily be historically as open to engagement or active in engagement. I think taking steps through the framework to engage with them is naturally going to help.
I think the framework will give us the insight, the intelligence and richness from our communities to make sure we can have a look at the health inequalities within our area and continue to address these.
In any work like this that's about culture change and shifting the way we work, you need the leadership, so you need people in your senior leadership saying, no, this is the right thing to do, we need to do this. But I think it's that top-down, bottom-up push to really create change together.
I do think that the framework is really adaptable. It's not something that's rigid and you've got to apply it, from phase 1 to phase 7 and work through it in that kind of linear way. It's something that's very flexible, which means that it is easy to apply to lots of different priorities and projects and programs and work streams.
I think it's really flexible. I think it can be adapted. We've done that within our own organisation to adapt it to make sure it's fit for purpose for us.
Every single project that you do, if it's not the whole framework, you'll be able to take different parts of the frame, different aspects of it, and apply it to the work where appropriate.
So I think the framework will probably be driven by ICS leads, but everyone should be getting involved. So providers, the BCS, individuals from communities, we should all be working together to make sure the framework is representing our experiences and those of the people who we exist to serve.
I don't think the framework is a replacement. I think it's an added tool. It probably won't be the last thing that we add to our toolbox around reducing health inequalities, but at the moment it feels like one I'm going to reach for in the next 12 months for certain.
Success will be measured by knowing that we've got the right people involved in designing interventions around health inequalities. It will obviously be seen in a reduction in health inequalities, so a reduction in avoidable deaths, in people who had long-term conditions and comorbidities. But those sorts of things will take time to be evident, so it's not something that will happen overnight. In the meantime, we'll see that we build interest with partners and communities.
I don't think this is just for engagement professionals. I think this is potentially for all colleagues across the integrated care system. They may want to work with engagement professionals to help them get started, but I think it's flexible enough that people could build it into all sorts of different programs, projects, strategic conversations. So I think anybody could use it.